Uh-oh, frozen. Well, hello, everybody. If you can hear me, we're doing our normal early morning glitch, and I'm just waiting for Dr. Rosensweet to come up. He was here a second ago, um, and he's out there in computer land. So soon enough, I'm going to try and welcome him in. I'm Carolyn, and there's Dr. Rosensweet in living color.
There we go.
Good morning.
Good morning, Carolyn.
How are you doing, Dr. Rosensweet?
I'm wonderful.
That is
Wonderful.
wonderful to hear. Welcome.
Thank you.
You're welcome. Again, welcome everybody who's going to be coming up. And I'm Carolyn, Dr. Rosensweet, and we're going to get started with our questions because we have to quit a little bit early because Dr. Rosensweet is very, very busy for a change. Busiest man I know on the planet. Okie dokie, starting with number one. Dr. Rosensweet, do we slowly lower our hormone intake as we move into our 70s, 80s, and 90s? Do you really need hormones later in life? I mean, really. Many doctors say that we don't need them or need to take them, um, and that we should really only be taking them for the shortest amount of time. And this is really confusing to me. Can you expound on that, please? Oh no, you're frozen again. Ah, how's this possible? Oh my God, you guys, your kind patience is so amazing. That it's just beyond beyond. And I know that you're coming in from lots of different places, and I really apologize. We're gonna we're gonna get this right one of these days. We had it right for 3 years, and all of a sudden we just
We're back.
it's like magic. It's crazy. I love it. Not.
Yeah, right.
And did you get
Carolyn, would you repeat the question?
sure? Sure. So basically, it states, do we lower our hormone intake as we move into our 70s, 80s, and 90s? Do we really need them later in life? Many doctors say that we don't, and we don't need to take them uh, later on, but we should take them for the shortest amount of time. And this is really confusing to me.
And I would like to help clarify that one.
I bet you would.
For 1,000 years, I don't think this question ever arose. And then in 2002, with the Women's Health Initiative, false reporting of the Women's Health Initiative, everybody got scared. What was false about it is it suggested risk, but in the study it said of no clinical statistical significance, which means they did not have scientific evidence for risk. And later it was proven by the same committee that there was no increased risk. Never mind, that bomb went off in 2002, and you could not put that cat back in the bag, and
Even
everybody
still,
got scared. Women got scared, healthcare providers got scared, and the whole field of menopause medicine got stunted because people just avoided it. And while other specialties were getting great, perfecting their art, their craft, their science, their knowledge base, there was a very, very slow moving train in the world of menopause treatment by a very few pioneers that were doing this. And the then when so 18 million women, American women, were on hormones in 2002, and it dropped to the low millions, maybe a million or two overnight almost.
yeah,
That's how
that's a lot.
terrified everybody got. And it turned out that so many of those women said, I can't stand this.
Yeah, I bet.
Yeah, great idea. Stop my hormones, but I'm telling you, I can't. I'm not sleeping. Everything is tanked, and so they sought alternative solutions. A lot of them sought out the world of compounded bioidentical hormones, and the healthcare providers, the physicians, the nurse practitioners, like myself, that we were deep in it. We were way into it. I saw that the study was false. Yeah, I didn't drop a beat. Yes, we're always at risk, but the science is we're at less risk for breast cancer, heart attack, and stroke if a woman is treated with hormones. That's the science. And you can read about it in chapter 3 of the book that Carolyn puts up, Happy Healthy Hormones, on our Facebook page. So when patients were going nutball, doctors tried to come up with a solution because they saw that it was far more health threatening to not be on hormones for a lot of these women. So they came up with this idea, no science behind it, no studies behind it. The idea was we'll take the smallest amount for the shortest period of time.
How does that help?
And that provided some relief. But later, this whole study was retracted. The science is trickling out. Still, a lot of healthcare providers have not been exposed to the retraction of that study by the original study committee, published in the original journal, that after 18 years of follow-up, there is no increased risk. Well, meanwhile, when a woman is having a lot of symptoms and she's not sleeping and she's waking up in the middle of the night and her mood is tanked and her energy is tanked, and you put her back on hormones and you dial it in to her individual needs and balances, and she feels better, what you're going to find is an optimal zone. Not too little, not too much. And I cannot think of one intuitive or scientific reason to ever change that for the whole time we're on Earth. And if you go too low, this whole theory of too little bit, you will not protect the bones. The women are going to have bone loss. If you go too low, the women are going to get vaginal atrophy. If you go too low, you threaten cognitive decline and arterial sclerosis. If you go too low on testosterone, yes, folks, testosterone, one of the greatest female hormones that ever lived. And males too. You know, we males, we like our testosterone too.
And we like that you like it.
You dial someone into the optimal zone and you protect the bones, you protect the vagina, so we know those numbers. So our counsel is every day that you're on Earth, dial it in and keep it dialed in. And I have a lot of experience with elderly women. And I'm telling you, they have no desire for dose reduction.
Yeah, right.
And it turns out young women, they vary as to how much estrogen, for example, they have. You can have some women who have a low amount of estrogen and they're healthy and they're fertile and they have regular periods and they can get pregnant and have normal childbirth. Yet other women, for them to be healthy and fertile and have regularly menstruating, they need this much, 3 times as much estrogen as this. There's a wide range of what is good for a woman. Varies individual to individual. The
Right,
menopausal treatment zone is right here. So we're not replicating youthful levels.
right.
We're not even getting them so high as that it would be equal to what the lowest of the young women need to menstruate. We don't go there. So there's no reason in the world to go into youthful levels because so much of the greatness can be preserved by coming in right below the youthful levels. Are there exceptions? Yeah. There are some women to restore cognitive function, which is absolutely critical if we can do that. They need much more robust dosages. These are rare exceptions. I don't want to dwell on the exceptions. But, for example, me, I'm a man. I take hormones. I take testosterone every single day. and ain't no way I'm going to stop taking it for every day that I'm able to open it. My main criteria is if I can open up the cap, I'll be taking it. Or if someone will open up for me, may it never happen.
It's a new job occupation.
So we're learning as we go, you know. There was the falseness of the Women's Health Initiative that got retracted. People panicked. Doctors tried to respond with some kind of decency, but all those ideas came out of nowhere.
I think that women are starting really after, so much information has come out, especially through you, and thank you, to learn that sometimes, yeah, they're not with the right person. So we do the doctor shopping, and we do that
Yeah.
doctor shopping so that we can find that perfect person, and it is doable. I've done it. So I
Mhm.
know it's doable. Thank you, Dr. Rosensweet, for that. I do know you have a lot of very personal experience with treating women in their 80s who had never taken hormones before. They
Yep.
got better, yeah, and got more years on the planet and could get out of low couches and low chairs, which were back in the 70s, I think, and without hands, like happily so. So, having dealt with you, I have to agree. I have to agree. And so I guess that would be a yes. You can go ahead and take them into your 70s, 80s, and 90s, and hundreds, even, right? Where'd you go? Well, you're back with me again. And Dr. R will be back up again. There he is. I can't hear you.
How about now?
Yes, now I can hear you. Okay, so I'm rushing through this so I can keep you. Question number two. Um, Dr. Rosensweet, I want to take Biased, and I asked my compounding pharmacy to make up the holistic oils for me, but they said that they could not do this for me. And I'm wondering why this is and how I would go about doing so. Thank you.
Um, Go into our website, bright.live,
Oh,
and ask to connect with Sherry or Karina,
Karina, yeah.
and they will help you find a provider and a pharmacy that does prescribe this. There's 35 pharmacies in the United States who do this, and Sherry and Karina will help you.
Okay, so bright.live.
Yeah, I'll put it in the chat.
Thank you. Thank you very much. Um, cool. Nice, nice, nice. All right. On to number three, because I know that you have a hard stop and it's an early hard stop today. um, I, the questioner says, am 69 years old, been on biohormone replacement therapy for 15 years, but I'm having some major incontinence issues, and it's not getting much better. Um, I would appreciate any thoughts on this matter from you because I know that you're dealing with women around my age group. Um, is there anything you can say about taking hormones and having incontinence still?
Absolutely. What we don't know from this questioner is if she's on testosterone. Being able to have healthy bladder function has got a couple major components. One of them is estrogen related primarily. It's a healthy vagina. Without sufficient estrogen, the actual lining of the vagina, called the mucosa, changes. It gets super thin, super dry.
Mm,
And since the bladder empties through a tube that ends in the vagina, that emptying opening can get irritated from the vaginal changes alone. That can really provoke cough incontinence, urinary incontinence. That's one component. Now, there's a second component that's major. The bladder is held up, and there's a rustling, there's a sound going on. I'm not sure what that
Sorry,
is.
it was me note taking.
The bladder and the uterus is held up by a sling, a big muscle that crosses then is at the bottom of the pelvis, and it holds everything up. It's called the levator ani. You can squeeze your levator ani by squeezing your anus. Let's all do it together now. 1, 2, 3, squeeze.
Yeah, music.
That's the levator ani. That holds up the bladder. It holds up the uterus. And without sufficient testosterone, women lose muscle. Women often see that. They get some flab in their tricep area, or they start noticing it's harder to get out of a chair or a low couch. It's harder to stand up when you're on the floor. You're losing actual muscle in your thighs and your legs. It's a well-known medical phenomenon. It's called sarcopenia. It's muscle loss, and it's going to happen unless you have adequate testosterone.
So adequate being the operative word.
And if you have sufficient testosterone, you also can prevent or sometimes even reverse sarcopenia of the levator ani. So what I didn't know about this particular patient is, was she on testosterone? And we're able to assess with great accuracy testosterone levels in any woman with the 24-hour urine hormone test. 24-hour urine hormone test. We know how a woman that we're treating, how her levels compare to a young, healthy woman. And we want to approach that with testosterone, with estrogen, progesterone, with all the hormones. With estrogen and progesterone, we tend to fall below a 20 to 29-year-old woman. That's fine. With testosterone, we're going to go into the low zone, the low end, or when there is sarcopenia of the levator ani or any other muscle, we're going to go into the medium range. We're going to see how much recovery we can get of the levator ani in a woman that's incontinent by really maximizing, optimizing the testosterone dose. We're not going to want to go too high. When a woman gets too high, she can get pimples, she can get a little mustache hair growth, chin hair growth. So there's bumpers there. We don't go too high, and we don't need to. The other thing that's very important is, like every muscle in the body, it requires exercise. And there is an exercise named after a Dr. Kegel. It's exercising the levator ani. And how we exercise the levator ani is we squeeze our anus. So on 3, squeeze your anus. 1, 2, 3. And you do a lot of those Kegel exercises, that levator ani squeeze. You do them 5 times a day, 3 times each time, as many times as you can remember. So the biggest chance you have, and I'm suspecting this woman that is not on testosterone, is to get really a nice optimal level of testosterone and do those Kegel exercises, and you'll have a chance of recovery. Also want to optimize your estrogen doses, because if you have any degree of vaginal atrophy, that's going to contribute to it. And one way you can tell is if you're having intercourse, if you're having pain on intercourse. If you're having pain on intercourse, you do not have enough estrogen. And one of the errors that I see made by people who aren't specializing in treating women with hormones is that they're giving way too low dosage of estrogen. For whatever reason, they're doing that. And these women are on numbers that are too low. I see it all the time. That's not what you're going to get when you are working with someone who's really trained with treating with hormones. But that can happen to you if you're working with someone who it's part of a broad-based practice. It's a small part. And so they haven't taken the time to really get the training and mentoring that they need to get great at this. So you could also be on low estrogen. If you're having intercourse and you're needing lubrication, that too is the sign that you've got a degree of vaginal atrophy. You didn't need lubrication 20 years ago, 30 years ago, 40 years ago. Unlikely that you did. So those are the three elements. You want to optimize all the ovarian hormones. You want to get the estrogens right, the progesterone right, the testosterone right, and the DHEA right, and do Kegels and have
You can pretty
intercourse
much
if you
do 'em
can,
anywhere.
because intercourse and orgasm is another major exercise. Even masturbation is another major exercise. You may not feel up to that, but head in that direction, because that contracts a lot of stuff down there.
Cool. Okay. Well, thank you for answering that one. I'm going to go through this one, try and get to the chats because we see you. I have very bad hip and back pain and many other symptoms too. I've read Happy Healthy Hormones. I've told my doctor all of this, and he very compassionately laughed and said other people's diagnoses are not his, and that I should rest and not read anything about the subject or on the internet. He says my pain and symptoms are inflammation only and has nothing to do with hormones. Could this be true? I walked out of his office with 3 prescriptions.
Excuse me.
Sorry.
Well, there's a couple components to this. One is we're still at a primitive time in the treatment of menopause. And the whole field got abandoned by the vast majority of licensed healthcare providers, doctors and nurse practitioners in 2002, and the recovery has not occurred. So if you go to a doctor who hasn't taken on the subject of treating women in menopause with hormones and isn't really extra training, we're not trained in this in medical school, we're not trained in it in most residencies. And training is minimal even in the female specialties. You need additional training of significant order. The body of knowledge is huge. So if you run into a provider who doesn't know what they don't know, which is universal for all of us human beings, we don't know.
But we
And
don't know what we don't know.
for some reason, there's fear of non-traditional methods of treating. It's universal. Not every doctor is afraid of what this new alternative medicine. It's just good medicine. No alternative, nothing alternative about it. Is how big is your tool bag? How many traditional tools do you have, and how smart are you at using them, and how many additional tools do you have that work, that are beneficial? And so we hear this comment from women all the time that when they go to their healthcare provider, they get a lot of pushback. And it's coming out of lack of knowledge and fear. So you may still be able to rely on your traditional doctor for their expertise. And I highly encourage you to do so. I navigate in the world of doctors. And I encounter resistance periodically, and I don't care about it. If I ask a gynecologist for assistance with one of my patients, the ones that I know are very gracious, and I need their expertise, and I treasure their expertise. I wouldn't go to them for hormone work. That's not what they care about for the most part. They love surgery. It's all they can do to keep up with their own field of endeavor, and so just to, navigating on the planet Earth has got its challenges. Now, pain. Let me tell you one story. I'm sitting in my office. I'm about to consult with a new patient, a 55-year-old woman, a high-end real estate agent. I'm meeting her for the first time. I'm reading through her questionnaire with her sitting in front of me. And I come down to the line of what medications are you taking, and she's on OxyContin. This is a narcotic. Many of you have heard about the opioid crisis, and here I'm sitting in front of a patient who's taking it daily, a couple times a day. And I'm saying to myself, do I really want to take on an OxyContin addict? And I paused for a moment, and then I thought, and I communicated this to her because she seemed like quite a reasonable woman. I said, one thing
I know this story. A good story too. Oh, Dr. R, come back. Um, just in the interim while we're waiting for him, I'm seeing that my doctor has me on bioidentical hormones bias with small dose of testosterone. I'm just so scared of cancer. Please reassure me I'll be safe. Um, while we're waiting for Dr. Rosensweet, I'll let you know that I had breast cancer twice and I had cervical cancer once. I've been on hormones for 6 years. And Dr. Rosensweet will often say a woman who has had breast cancer and has had that cancer treated properly stands a way less chance of recurrence than a woman who does not take hormones. He'll also say that hormones do not, repeat, do not cause cancer. And when he does come back up, I'm going to try and ask this question because he has a hard stop in about 15 minutes. But the book Happy Healthy Hormones and also the book Estrogen Matters are both excellent. Your name's not coming up. I see you as Facebook user, but it's very dear to my heart, and I know that that fear is very real. Um, I went through 56 doctors over 17 years to finally get on hormones because that fear was so real in them. And I feel great. I go to school, I move, I walk, I laugh, I sleep, I do all these things. And I think that when we can get over that fear, we can do well. But I don't want to speak for him per se. But having done these interviews with him for about 3 years, almost every interview we do, he will say hormones do not cause cancer. And that is the science. And I believe him. And I use the hormones that he invented, and I feel very, very good in so doing. So I hope that answers some of your questions. Um, and I'm waiting for Dr. Rosensweet to come back. So anyway, for that Facebook user, I can't get down on my chat, but the book Estrogen Matters is phenomenal. And Dr. Avram Blooming blew the socks off of that report, the WHI, that really scared women like crazy that hormones do cause cancer. They don't. Other things do, uh, but hormones do not. And Dr. Rosensweet will say that straight up. So there's that. Um, he will also address, yes, please. And you could download Happy Healthy Hormones on the ins and outs of menopause with Dr. David or David Rosensweet, MD. If you like, it's free. It's the PDF version. It's at the very, very top. But I'll go ahead and I'll put that out there, so you can just click it and download it. It's an excellent book. And then again, Estrogen Matters, where Avram Blooming and Carol Tavers do an amazing job. You can also go to Peter Attia's podcast, number 42, where he interviews Dr. Blooming and Dr. Tavris, and that's very, very good about their book. And then Happy Healthy Hormones, which gets you all the way through all of this. It's a fun book, it's a lovely book. Yeah, and so that's that. And then thoughts on high SHBG. Again, I'm pretending to be Dr. Rosensweet because I learned all this from Dr. Rosensweet. I can't tell you so much about what my thoughts are other than I have had high SHBG, and I was really freaked out. But Dr. Rosensweet has many, many times said it's pesky, yeah, um, but it's not dangerous. So try not to be scared on that dangerous part. We bind up these hormones, I guess, in a protective device. Um, for whatever reason, and there are ways certainly of dealing with that. Um, and I don't know if you guys all know, but we do have a group called the Ins and Outs of Menopause, which I started. Dr. Rosensweet came aboard, and we made it the Ins and Outs of Menopause with David Rosensweet, MD, so as to get information out to everybody. But as you can see, I'm the one doing that right now. But I'm really mimicking everything he's taught me, and he said these are not my ideas. And I can't get down on my chat. I'm wondering if I should reboot. Um, so hang in with me. You guys might disappear, but let me see if I can go ahead and reboot and get you back. Got it. Lowering your SHBG for libido. Talk with your doctor. Sometime I don't know. Yeah, cool. Or just come back on. I'm gonna reboot and see if I can get Dr. R back. Hang on. Be right back.